Everyone, hope you're all doing okay on a very, very warm Tuesday. Hope we didn't all have too many AGPs in this hot weather, because that wasn't fun at all. We're going to get Kreena Patel on to talk about some endo. We're going to talk cracked teeth, those COVID crunchers, a little bit about materials and equipment, and we're also going to just go through some sort of tips and tricks and more unusual anatomy. Looks like we've got Kreena on already. Here we go. Drum roll. Let's try it now. Here we go. Payment's on. I pay. Right. Hi, Alexandra. How you doing? How's your holiday, man? You get back all right? Payment's on. You want to listen about endo? We're not even talking internal bleaching payment. I hope you can be okay with that. Lots of people checking in, which is good. We managed to be on time today. Didn't have to have to be running late. Bless him. Not really sure. Can't get Kreena to join. Let's try it this way. Oh, might have to restart it. Hey.
Hey.
Thought we're never going to get you on.
Yeah.
How you doing? You okay?
Yeah, I'm good. How are you?
I'm good. I'm good. I hope you didn't have too many AGPs today.
3.
Only the 3. But
Yeah.
you got long ones. That's the problem, isn't it?
Yeah, yeah. It was it's not too bad because the surgery's got AC, but I think if it didn't, I'd have a real problem.
Yeah, it'd be an absolute nightmare. I wouldn't be doing that.
What about you? Did you have a lot?
2, 3 as well. Not too bad. I did a bit of perio today. Unbelievable.
Ah.
Unbelievable. 2 denture impressions though, so it's all good. So it's all
Yeah.
in balance, you know. Not an endo in sight though, so sorry about that.
Is that
I
it?
mean,
Like for you and endo, you don't do any more?
no, I do. I do a lot of, well, not a lot of. I do a fair bit of rewalls and sort of explorations of cracked teeth and things. And our
Yeah.
endodontist always says I should look at doing a bit more endo, but I think he's just, I don't know, doesn't enjoy doing the rewalling. But
Oh, okay.
no, I quite enjoy it, to be fair. I like endo, but yeah, I don't fancy doing
Not as
like
much as dentures.
not as much as dentures. No. There's no upper 7s on my dentures either, so you know that's all good. So we're going to chat a whole different range of endo stuff today, but do you want to just give everyone a bit of an intro about yourself in case anyone doesn't know who you are?
Yeah, so my name's Kreena Patel. I'm a specialist in endodontics. I work mainly in private practice, so between 2 sites, one based in Mortimer, which is near Reading, and one in South London. I love to teach, so I do a lot of private teaching, and I taught on the specialist program at King's for 4 years after I qualified. So just recently stopped doing that for more private teaching, but otherwise was doing a fair bit of that as well.
When were you doing the teaching at was it at Guy's or
At
close
Guys, yeah.
at Guy's? When did you finish that?
This January. So
So
I was
you wouldn't have been there when I was there, would you?
uh,
2017 I left.
2017. So yeah, I would have been, I think. Yeah, I would have been.
Oh, is it
Yeah.
just the postgrads or?
Yeah, mainly postgrads. I did a little bit
Okay.
of undergrads towards the end, but mainly postgrad teaching. Yeah.
Oh, so you might have seen me doing some like hand filing on a
Oh,
level
yeah.
7 or something. Up on the specialist floor where you had to book it like 2 months in advance.
Oh, okay. Yeah. I sort of, yeah, a few undergrads doing that kind of thing. So
Yeah, that
yeah.
wasn't fun. That wasn't fun. So the first thing we're going to go through, we had lots of questions about sort of materials, equipment, all that kind of umbrella. So we'll just go through a few bits. I think one of the questions, more of a general thing, was about loops. So do you
Mhm.
have any particular, preference? Obviously, probably more magnification, the better. You're going to be less worried about field of view. But what do you use loops? Or you microscope?
So I personally use a microscope, but I also use loupes as well. So when I first start an endo, I dismantle the restoration completely. So for that side of things, I use loupes. And when I'm rebuilding walls back up, so that you do a pre-endo restoration initially. So all of that side, I tend to use loupes. And then when I'm doing the root canal treatment, I tend to switch to magnification, like microscope magnification. I would say in terms of loupes, try and get something that's going to be useful for your whole range of dentistry rather than focusing on endo, but I do think going to something like a 5 mag is very useful, as long as you maintain your field of view. So I've got one set of loupes at the moment from Bryant Dental, and I think they're fantastic. I've got some new ones coming from Oroscoptic, which are 5.5, so I'm yet to try those out.
That extra 0.5, yeah.
Yeah. With a new light, but I do I love my Bryant Dental ones. I think they're fantastic. And for endo, really, you do need magnification and light if you're aiming to do it to a good standard. I don't know how people do it with their eyes, because sometimes I get called into like our associate surgery, like, oh, Kreena, come and help me find this canal, and they're looking with their eyes, and I'm like, can't see anything. Even I can't do that, even with having done a lot of endo. So I think loupes are really important.
Yeah, I mean, when I do the odd endo, I would, sometimes you just look over the top of your loupes into your mirror and just be like, I don't know how. Like undergrad, I didn't have loupes, and just think, how did I ever actually get into any canal ever without loupes?
Yeah, it's guesswork, isn't
absolutely.
it?
And I'm looking at upgrading to some fives. I think I've got 3.5s.
Yeah.
But I think for most of what I do now, that's sort of enough. But I do quite fancy zooming in on some preps.
Yeah. I think the thing is, it's quite a jump to go straight to 5.5s. But at the same time, like with the Bryant Dental ones, I don't know. I think it is possible. It's almost
they're quite wide view, aren't they?
They are. You almost, with the 5.5s, you maintain the full arch in your view, which is pretty good. So yeah, it was a little bit of a jump, because initially I was using 2.8 for that type of work. Probably took me about 2 or 3 weeks to settle into the fives. But once you move on to the fives, you don't want to go back. So I do think sometimes it's worth, if you just want to invest in one set of loupes, to go to the fives, as long as it maintains that field of view.
Have you tried is it Oroscoptic that do the eye zoom ones that are like 2, 3? Are they 3? What are they, 3, 4, 5 or something like that?
Yeah, they have a really good range actually. And when I first tried them on, because I've been working with Oroscoptic on my hands-on course, and when I first tried them on, I thought, oh my god, they're going to be really heavy. The zooms on the different levels aren't going to be good, but actually they are a really good loop. You maintain, it flicks from mag to mag really well. So if you're a little bit worried, that's a good one to go for.
But as you say, once you go to the 5, you don't really go back. So I can imagine it's all well and good for the first couple of days, and you're clicking around, and you set them to 5, and then never go back again, probably.
Yeah, exactly. I think then you end up settling on the 5s.
Yeah. Any other sort of instruments or sort of equipments? Are you ultrasonic irrigator, activator kind of thing, or anything like that?
So when we talk about the loupes, I think one of the big things to also talk about is using a front surface mirror. So a lot of people use rear surface mirrors for general dentistry. They're a little bit cheaper than a front surface mirror, not significantly, but using a front surface mirror really does make a big difference when it comes to endo and trying to guide your file into narrow spaces. So front surface mirror, if you're not using that already. In terms of ultrasonic activation of root canal irrigant, I think that's really important as well. I personally don't use ultrasonics. I use a sonic irrigator. So I tend to use the Endo Activator by Dentsply. The reason I don't like ultrasonics too much is because they're metal instruments, they can potentially break when you are activating your irrigant down, especially a curved canal, something like that. And also it can start to prepare the canal walls. The worst thing you can have is that you've just done your beautiful endo and you're just activating your irrigant and suddenly an instrument breaks. So I find the Endo Activator a lot safer. It's not as powerful as an ultrasonic because it's a sonic irrigator rather than an ultrasonic, but it's made of plastic, so it can literally hit the canal walls. It's not going to prepare them, and you notice literally your irrigant goes cloudy when you use it. which, I basically carry on using it until my irrigant is nice and clean, even after I've activated it. And then, actually it's, really cleaned the canal walls well.
Fine. So like the activation for people that haven't been, I mean, I've not used the sort of the sonic irrigant. So what's the actual action that it's doing to improve the efficiency or effectiveness? How's it?
Yeah. So basically, once you've finished all your preparation of your canals, you place irrigant into the canals, and then it's like a little plastic tip that matches your final file size, and then you just literally pop that into the canal, a couple of millimeters from working length. Then you turn on a button and it starts to vibrate. So what you're doing is you're basically pushing your irrigant against your walls, into your isthmuses, into your tubules, and it's literally just a vibration action. It's almost like I guess, when you floss with water, where you like pushing things along, it's just doing that, and really like, agitating the irrigant so that it touches all the canal walls and things like that. So you do it for about 30 to 60 seconds per canal normally, and then you take it out, re-irrigate. But I tend to do it over and over again until it's nice and clean in there.
And so you say you're doing that when you've sort of done sort of full preparation to length, rather than you're sort of intermittent as you're going, maybe with initial files. You're just maybe doing a bit of irrigant normally and then cracking on with your next file.
Yeah, it's literally just before you're taking your master cone x-ray, when everything's nice and clean. And then I spend some time actually just purely irrigating the canal after the shaping is done.
Well, that sort of comes on to find like almost sort of the final, well, we've had a question actually about sort of your sort of preferred method of canal preparation. So maybe actually we'll come to that at the end as a sort of general sort of step by step. Because I wanted to ask about your like finishing protocols to say after you've done master cone, what's your saying? But we'll come back to that. Yeah. Any other useful instruments or equipment that maybe people aren't using in general practice?
So in terms of ultrasonics, I really like the piezo. So the piezo is much more useful for endo compared to the cavitron, for example. The cavitron is great for perio and things like that, but it moves at in a sort of elliptical motion, whereas the piezo ultrasonic moves in a linear motion, so up and down. It's a lot more powerful than the cavitron, so you get a higher sort of efficacy out of it. And it's also, you can use it without water, so it's really useful for finding extra canals or getting rid of calcification where you don't want water on, so you can actually see what you're doing. So I think that's really useful as well, if you have a piezo rather than a cavitron for endodontic treatment. The other really useful thing that I find is a gooseneck burr or a long neck burr. So this is basically, it's like a rosehead burr, but often a lot smaller than a rosehead burr, and it has a long neck. So if you imagine one of your rose heads on a sort of long neck, what it means is we can actually use it without the head of the handpiece getting in the way. So we can do quite fine motions compared to using a fast turbine burr. So for example, if we're looking for an extra canal, those kind of things, it's really useful because we can do minute motions compared to, taking chunks of the tooth. And they're really cheap. They can go in your slow handpiece. So they're really useful as well for endo treatment.
So it's like a sort of rosehead Gates Glidden hybrid sort of.
It's literally like a rose head. You imagine a long shank on your rose head. So actually when we use it, we can see down the shank and exactly what the burr is doing. Whereas if we used a conventional rose head, firstly, they're too short to, touch the pulp floor. But also the head of the handpiece would mean we can't actually see what that burr is doing. So we can, over prepare. Whereas this gooseneck burr, because of that long shank, we can see exactly what's happening at the tip of that burr. So really useful for lots of things. So like I mentioned, finding extra canals, removing calcifications, even at the end, if you want to tidy up your GP so that it's, flush with your canal orifice, rather than sticking it into your pulp chamber. Really useful for doing that because it produces heat while it's rotating, so it can just nicely flush off your GP as well. So probably
that's where I use a dry ultrasonic.
Yeah, also very good. Yeah, also very good.
That was my biggest thing in piezo.
Yeah,
that was my biggest thing in FD of doing, because standard you have to do hand filing and cold lateral, and I'd always be like so worried about removing excess, and you do it with an excavator and it cools, and then you
fill everything
and one of the trainers, it was like at the end of the day, he was just like ultrasonic without water, and literally went that day and changed my life. It's
That's
so
what the
much easier.
gooseneck will do to you as well. The gooseneck's really
Yeah.
useful. It's because some people
I'll
don't
get
have a
Vandalay to
piezo.
order some. Yeah. Well, that was the thing. I work when you work without your ultrasonic not working or something, it just endo just makes it so much more difficult. Um, while talking cold lateral and things, rotary all the time.
Yeah, pretty much. I
Yeah,
do much
the
prefer
odd
rotary.
difficult one, but yeah.
Yeah, I mean, you do obviously need hand files. So I always do a glide path with hand files first. So
Hmm.
usually my first file that I pick up will be a size 10, just to get a glide path. But then following that, I'm moving on to rotary files. The main reason is because hand files, as they become larger, become quite stiff. So you're more likely to ledge canals and change the anatomy a little bit when using those. So it's a big reason why initially people can get to working length with their hand files, for example, a size 10, and then they move up and do their final prep with a size 20 or 30 or whatever, and then suddenly they lose the length of the canal and they can no longer get to the apex. And it's because when the file is stiffer, it wants to straighten, and then you can end up with like a zip at the end of the root canal, so you can then no longer get to length. So I think it's moving on to rotary is really useful, and people are sometimes scared of that because obviously it's a new instrument. I often find sometimes older dentists find that because they're so used to hand filing, and then to
Hmm.
switch to something that's obviously spinning around is difficult. But I think once you make the switch, you won't go back because it's a far faster method of preparation, and you just get that flexibility in the files, which means things are much more predictable.
Absolutely. And do you have a preferred system, or have you got certain cases where you use one or the other?
So in practice, generally, I have everything. So every file on the market tends to be what I have. But my favourite one is ProTaper Next. So it's
Hmm.
a file system by Sirona. My favourite rotary file is the XA file, which is the first orifice opener as part of that sequence. And it's a coronal flaring file. So it's quite a short file, which is quite chunky. And it's really useful because it's shorter. Before we can get sort of longer files into the canal, especially at the back of the mouth, it just helps give us that access because it is shorter to flare the canal so that longer files can go in. And coronal flaring has so many benefits. I mean, the first one is it allows our hand files to go in much more uninterrupted so that we can actually feel what the tip is doing rather than the file being locked throughout the whole of its section. It removes the majority of bacteria before we put in a hand file. So the majority of bacteria is coronal. So if we
Hmm.
get rid of that and irrigate well with a flaring file first, then when we put our hand files into working length, we're not pushing bacteria down the canal. So loads of benefits. So the XA is probably my favorite rotary file. I sound like you with dentures. I don't think
Is
anyone can have
S
a
is
favorite
XA the
rotary
same
file.
as or not the same, but similar to SX?
Yes, yeah. So the
Yeah,
SX is a heat
is
treated
that
file as part of the ProTaper Gold sequence.
gold? Yeah.
I prefer the XA because it is actually a little bit more stiff than the
Okay.
XA, so you can actually flare a little bit easier and quicker with it rather than the SX because it's heat treated. It's a bit more flexible, which is
Hmm.
beneficial when you are struggling with access at the back of the mouth because you can pre-curve it. But
Hmm.
it does take a little bit longer to then flare the canals because of the heat treatment. And then following the XA, it moves on to X1, which is again a really brilliant file. It's sort of 17 at the tip, and then it has like I think like a 4 to 6% taper along its length. And then I don't tend to finish on X2, which is actually the one that the sequence is part of.
Hmm.
But with endodontics, everything's moving on to sort of narrower preps now. So
That was
I
the
try
next
and be
thing I
a
was
bit
going to
more
ask. Yeah.
conservative. So I find the X2 a little bit chunky, and so I tend to switch to a Coltine system, micromega system called One Curve. So I finish on a 2504.
I'm pretty sure that's what our endodontist just started having a play with as well. I know Coltine because I'm chatting to them about some denture stuff. I know they came round to see the endodontist as well, and he was talking about this more sort of minimal intervention endo, if that can be a thing.
That's it. Yeah,
Um,
exactly. Trying to preserve a little bit more tooth structure.
and interestingly, he did it's a case. I'm not sure if he's posted it actually, but it's my patient, and it's side by side. It's a 6 and a 7.
Okay.
And he's used one system in one, and then she's come the next week and he's used this system the next. So it's quite interesting to see the difference, and it's a lot more minimal, a
It is.
lot more
Yeah.
minimal. But where is it in? So are we saying that conventionally we're over preparing canals if we go into, you know, an F2 or F3 or whatever, and we're
Yeah. I
saying
mean,
actually we
an
don't
F.
need to go that far?
Yeah, I don't think so. I mean, the main reason we prepare a canal is so that we can irrigate effectively. So that the prep itself doesn't really do much in terms of removing bacteria. But the main reason we do prepare is so that our irrigant can get to length. And now we have sort of plastic syringe tips, which means that we can irrigate a lot deeper in the canal without actually having to prepare a significant amount of that canal. Also, we activate our irrigant, so things like that means that we can actually irrigate to length well without actually having to over prepare the canal space. And the main reason that root treated teeth fail is due to root fracture in the future. So as long as the endo's done well, you know, that's the main reason for failure. So if we can try and preserve a little bit more dentine, potentially that means that the tooth will last a bit longer. So I think trying to, I mean, it's difficult because not all endodontists have that same school of thought, and the evidence is still catching up with us. But I personally think, you know, as long as we are able to clean well and irrigate well to length, that's as big as our preparation needs to be. So I used to quite like Pro Taper Gold, but I find the preparation quite heavy now because it's quite a large taper. And I used to finish molars usually on an F1. I'd never used to take it to F2 or F3. That's probably far too big for a molar, in my opinion. But now that's why I've moved systems a little bit, because I just think that taper's pretty heavy. We don't need to go that deep.
Yeah, and it's I think it's going to be interesting if it not takes off, because that makes it sound like it's like a fad. But you know, if it becomes more popular as more stuff comes out about it, yeah, I could see it going another way. If you're going, well, it's a thinner preparation, I can see people being like, well, you know, it's finished quicker, and then it's not
It
going to be that
actually takes
amount of
longer with that.
irrigant. And no, if you're doing it properly, exactly. But I can see it happening where people
Yeah,
go, if I'm using something narrow, I haven't got to widen it up. It's not as many burrs, and
yeah,
that actually will end up with not because it's all about, as you say, it's about irrigant in the canal, right? It's about
yeah,
the chemical disinfection of the canal.
yeah.
So
And it's
you've got
actually
to
quite hard
have all
to
your
see.
toys to do it properly.
Yeah, it's actually quite hard to see your endo go from something that conventionally looks quite nice on a radiograph to something that is a bit thinner, because you're like, oh, it doesn't look as good as, you know, those beautiful tapered shapes. But you get used to it after a little while.
Now, I think I say Vandelay's really enjoying it, so I'll definitely be keeping an eye out. I think should we? Oh, so the last thing on materials people want to ask was just about strengths of hypochlorite and things like that, because I know you can get various ones. What's your go-to? Do you ever mix it up, or is it always just
I
same one?
tend to use 3%. So I know the question was on, you know,
It was
5%.
5%.
So you can use anywhere between 0.5 to 6% hypochlorite. The benefits, I guess, of using a higher concentration is it is more antibacterial, but that equally comes with some negatives. So the negatives are, if you do have a hypochlorite extrusion, you get more severe symptoms, obviously, because of the concentration. And also, higher concentrations of hypochlorite are more damaging to dentine. So we know that hypochlorite damages dentine, which can result in fracture long term of the dentine. So that's again a little bit of a negative. And the main thing with hypochlorite is how much we're irrigating. So we want copious irrigation, replenishing of our irrigant very frequently, and that almost is better than actually using a higher concentration of irrigant. I tend to heat my hypochlorite. So I have a little baby bottle warmer, which wasn't very expensive. It's like a Tommy Timmy thing. And I put my hypochlorite into that, which heats it up. And actually the evidence shows that makes it more effective. So more antimicrobial and better at tissue dissolving. So if you use, I've forgotten exactly the concentrations, but if you use, I think it's like 5% at room temperature or 2% at body temperature, so it's warmed up to about 30 whatever degrees, then actually the efficacy is exactly the same as using a higher concentration, but you don't have all the negative effects, so the extrusion effects or the damaging of dentine. The only thing you need to be a little bit careful of is if you do heat it, the efficacy gets better and then worse. So don't heat all of your hypochlorite, only heat what you need to for that patient and then discard the rest of it.
Fine.
and use a new batch for the next bit.
Well, there you go. People use your fancy composite heater for your next endo.
Yeah.
That'll sort it out. So I think, should we jump onto cracks, which was the main one that people had loads of questions about. So, I mean, first up, as an endodontist, I've seen so many more. That makes it sound like I'm an endodontist. No, asking you as an endodontist, I've seen so many more cracked teeth since lockdown one. COVID clenchers, COVID crunchers, or whatever. Is that
like
translated
that,
to
in
your practice? All mine. Is that translated to your practice? Are you seeing suddenly much more cracked teeth and
yeah, I mean,
everyone
as
going
the
for it?
years have gone on, I've seen more and more anyway. So I feel like it's all going up. But since COVID, there's definitely been a big increase in numbers of cracked teeth. And I think you're right. I think it's the stress of everyone being locked up, or everything that's been going on. So yeah, definitely, and not being able to see a dentist. So I guess some of these patients would have presented earlier. And now I'm seeing them as an endodontist, whereas before maybe their dentist would have been able to fix an early crack compared to referring it and me seeing them.
What comes to see you? So I think first up then is, if we're going cracks overall, diagnosis. It's always the sort of thing that I always say, cracks are very difficult to diagnose, location, especially when early on. So have you got any tips for, vague sort of top right, top left? Is there anything that you can use? Are you a tooth sleuth? Is there anything in the history that helps?
Well, if we start with history, there's a lot of evidence I mean, I'm sure you know all of this, but there's a lot of evidence to show that if a patient has had a crack before, they're very good at diagnosing that they've got another crack. For example, with me, I've got a crack and on my lower 7, and I know that I've got a crack on this side. I know what that felt like, and so if I get one on another tooth, I know that I've got a crack in my mouth. So sometimes it's that patient history that is very useful. That I'm prone to cracks and that kind of thing, and then you look more carefully for that sign or symptom. It's quite nice to know what teeth do crack more often. So lower 7s are the most common teeth to crack in the mouth, followed by the lower 6s, followed by the upper 6s and 7s, followed by the upper premolars. So quite often, I mean, if we look at me, for example, I had pain when having raspberry seeds. Couldn't identify which tooth it was coming from, but I knew that when I had raspberry seeds, I'd get a short, sharp, pain on biting. I was convinced it was my lower 6, but if you look at all of the signs and symptoms, generally it's the lower 7 that cracks first, and lo and behold, it was my lower 7. So it's nice for a dentist to have those teeth in mind, because it helps you identify what's going on. Checking the occlusion is really important. So, RCP, ICP slides, things like that. Any rotated teeth or high cusp-fossa relationships, that kind of thing is very useful at diagnosing those things. All the standard stuff like, is it TTP? Any isolated pocketing, which could mean a crack has extended into the root. So for endo, we don't do a normal BPE. We just, we literally walk the probe around the gingival sulcus and look for isolated pocket, which can indicate the crack's gone down. Transillumination, quite often people's light cures will, also have the function for transillumination. So have a little look at your light cure manual and see if that will help, because where the light hits the tooth, if there's a crack, it will stop. Staining, again, that's quite a good way. So putting like caries detection dye on a tooth and seeing if you can see a stain. But I mean, most often I'm using my tooth sleuth, which I think is really, really helpful. Sometimes patients don't get pain on the tooth sleuth and only get pain when biting on a cotton wool roll, because it's that sort of sliding function that's doing it. Or sometimes cutting up a rubber dam sheet and getting them to chew on that can sometimes stimulate.
Okay.
I find heat testing quite useful. So normally we would do cold testing, and for sort of 99% of people, that is the test that we do to check for hypersensitivity or anything. But there's been a couple of patients that have been referred to me that have only had pain on hot, and the dentist has not been able to diagnose it. I've done everything, not being able to diagnose it, apart from using this heat test. So I get my nurse to boil the kettle, and then I basically, in an endo syringe, draw up the hot water into the syringe and individually isolate the teeth that I think it is. Not boiling water, but it would be like hot tea, you know, and then I have my nurse ready with the suction.
Also, I thought they enjoy that.
But sometimes, yeah, it's been, I think I can think of 3 or 4 patients. It's been the only thing that's made me realise that this is the tooth that's responsible for the problem. So it's, I mean, it's more for cases of obviously irreversible pulpitis rather than early cracks.
Yeah, so particularly bad cracks probably is more.
Yeah, for ones that are now bordering irreversible pulpitis, of course, where hot's starting to trigger the pain. But that's the test that I never used to do, and you know, more recently, it's something that only when I really have to do it will I do that. What else is there? Tooth sleep we've talked about. Those are the main things, aren't they? So I think those are the big ones that I tend to use.
Perfect. And well, we sort of almost went into prognosis there when we sort of said, oh, when it's irreversible, and also sort of, I'm assuming, you know, if you're getting a pocket and it's extended to root, you're probably thinking not the best prognosis. So have you got like a sort of a checklist or something that sort of rates the prognosis, and any sort of thoughts on that and how you go through that?
Yeah, so if we're talking about teeth that now require endodontic treatment, I'll tend to open up the pulp chamber, have a little look at the crack and try and investigate it slightly. So obviously, if it's a vital tooth, we're talking about onlays, which I'm sure you're much better at talking about than I am. But if it's gone to irreversible pulpitis or a necrotic pulp, then what I tend to do is open the crack just so I can investigate it. So what I'm looking for is an isolated pocket at the crack edge. And before, what we used to say was if there was an isolated pocket at the crack edge, that tooth was then unrestorable and required extraction. But there is some good evidence actually that we can treat teeth with isolated pockets as long as they haven't gone too severe. So for me, my cut off is if it's got a 6mm isolated pocket at the edge. And at that stage, I am telling the patient this is the prognosis of this is very guarded. I do tell them the crack has started to extend into root and all that kind of thing. So it really is a decision for the patient. I tend to take a photo at that level and sort of explain to them. And then if they want to try, then I do. And there's a fantastic paper that came out recently by Davis and Sharif. They treated cracks with up to a 7mm isolated pocket and a cracks that had gone up to 5mm into the canal orifice. And their 2-year success was about 100%. Their 4-year survival was 96%. And their 2 to 4 year success rate was about 96%. So actually the evidence is sort of moving forward a little bit to say, actually, should we be treating more teeth with cracks rather than just extracting them? And we're not saying that these teeth may, last forever. But for some patients, having a survival rate of that is, quite acceptable, and seeing how long they last. And I've been treating sort of cracks with an isolated pocket of up to about 6mm for about 5 years or so. And I've had probably 2 or 3 come back with problems. So I think it's worth considering with the right patient, with the right attitude, to try and save teeth that we wouldn't have maybe done before.
Yeah, it's certainly time to save for the implants, isn't it?
Yeah, yeah, exactly. Yeah.
So essentially what you're saying, you'd say it's like a lower 7, you've taken out your MOD amalgam, and you're then probing at that crack line.
Yeah. So I like to open the contacts. Yeah, I like to open the contacts enough. So I'm not chasing the crack down subgingivally or anything like that. But I do like to open the contact point enough that I can probe the crack edge to see if there is an isolated pocket, because that will give me an idea of prognosis for me to tell them. And then I like to open the pulp floor and open the canal orifices just very slightly. So I'm looking, if there's any crack that's extended across the pulp floor, that is an automatic extraction because they don't do well. And if the crack is extended, for me, it's more than 2 to 3mm into a canal orifice. For me, that's then an extraction. If it's less than that, then again, I'm telling them more guarded prognosis, but might be worth giving it a go. But then when I do treat them, and this is the same for the Davis and Sharif paper, what they did was they placed composite below the level that they could see the crack extending to give it a bit more of a barrier, because obviously GP doesn't seal very well. Whereas composite seals a lot better. So, really sealing coronally is key.
And then for those kind of cases, afterwards, are you sending back and saying always onlay, crown? You know, is there a cutoff where you think one's better than the other, or are you just trying to always preserve and go onlays these days? What's the thoughts there?
So I prefer onlays in terms of they're much more conservative, but for cracks of that level, so cracks that have, you know, that are extending subgingivally, I like the margin of the crown to extend slightly subgingival in that area because I feel like it holds the crack together better. So I think in some cases there, I'm saying crowns are slightly better than onlays. But if we're talking about a vital case, then definitely an onlay is better.
And that's, yeah, just leading me beautifully. So that was the next I was going to ask. So the like endodontists I work with generally says unless you know it's going to go non-vital, onlay first. Obviously consent and whatnot. But
Yeah.
he's also going, well, I can do a really nice super minimal prep through your onlay, and I know it's sealed. And what are your sort of where do you stand on that? Do you think that's, you know, reasonable? Because you know you're trying to, but if you say you've got this crack flying through it, then probably not.
Yes, if the patient's got sort of reversible pulpitis symptoms, then it's an onlay for me. Anything that's then bordering irreversible pulpitis, I'm then saying we do endo. And if it's necrotic, of course, obviously it's endo. But for me, one of the obviously you work with a range of people, so sometimes onlays come back. Obviously, the ideal way to place an onlay when you've had a cracked tooth is to replace the restoration underneath. So, for example, if that tooth has an amalgam in it, to remove the amalgam, put a composite in, and then put an onlay on top of that. So, you know, everything is nicely sealed. There's no problems underneath the old restoration. There's no caries or anything like that. And when a restoration has been done like that, then I would be happy to do an endo through that. But sometimes you don't always see that, and so therefore sometimes I do tell patients actually if this is done, then what we'd have to do is strip it out again to investigate the crack, to then do the endo. So if it is borderline going to irreversible pulpitis, I tend to do the endo first and then get the cuspal coverage on it, because I think that saves quite a lot of headache. But if it is reversible, then obviously that would be, we can do and it's a brilliant restoration that's been done like you do, Rupert. You know, that was absolutely perfect.
I don't share those. You haven't seen those. So.
That's perfect for me to do, you know, for you to do a small access and do the endo through. The only thing I do warn the patient though is that I can't then investigate the crack, because obviously when we do an onlay, when we do an endo through an existing when we do an endo, so it's too late at night, when we do an endo through the existing onlay, we can't then see the peripheries of the crack. I can't investigate it how I would normally investigate it. So for isolated pockets and things like that. So hopefully that's all done before the onlay is done. And if it hasn't, then obviously we can do it through, but we have limited visibility.
Well, we've now got all your top tips on how to investigate them properly, so we're all going to do that when we're doing our onlay preps. That's sorted.
I guess the only other thing is crack width is quite important. So obviously, if the crack is wide and it's got debris in it, that's got a much lower prognosis, and obviously probably that's an extraction. If the crack is narrow, so obviously if it's stained, we know it's leaking, so there is again a slightly lower success rate. If there's no stain but just a crack, then slightly better prognosis as well, because obviously it's thinner.
Stain to what degree? Because obviously a lot of the time you get a crack and then you'll get caries. Are you talking stained approaching pulp chamber or?
Yeah. So when we've now opened the pulp chamber, if we could, some cracks you see and they've got zero stain inside, and you think actually it's a slightly better prognosis. Some have like a little black line, and again I do treat those, but we know that actually there is some leakage that's happening through that, and then some are actually wide when you go into them and you think, oh, there's actually debris there, and for me that's probably an extraction. If that's, you know, how wide it is, if it's wide down to the level of the pulp chamber, then we think actually that's probably an extraction.
It was probably going to split in half that night.
Yeah.
And then the last sort of thing that people want to talk about was, or I want to talk about really, was sort of more sort of unusual anatomy. Now, I was very lucky to do a bit of a beta test for your upcoming online course, cheeky plug.
Thank you for doing that.
And you covered that really, really nicely. So obviously MB2 is the bane of everyone's life, because you'll be able to rattle off the stats for me, but
Yeah, about
A very
96%.
a depressing number of them have MB2. Any other particular ones? But do you have any tips for MB2 to start with, and then we'll look at some more weird and wonderful ones?
Yeah, so MB2s, if you look at stats, it's about 95 to +% in upper sixes. Upper sevens about 60 to 70%. So again, quite a significant amount even in upper sevens. Tips for finding it. So if you draw a line between your MB1 and your platal, we have a little picture here, I think.
Yeah, go for it. Go for it.
So I'll pop that up.
Here's one I made earlier.
We literally had this prepared, didn't we? I've got this up.
We do a little bit of prep for these guys.
Oh gosh, and I'm still trying to find it. I don't know where it's gone. Oh, here we go. Here we go. I've got it.
We got it.
So what we're doing is we're drawing a line. This might be a little bit backwards in the camera, but we're drawing a line between platal and MB1. And then we basically dissect that line with a line from distobuccal. And that in most cases is where MB2 is. Not every time, but in most cases. So that's where I would start looking for MB2.
And instrument-wise?
Instrument-wise, it's the only file that...
Ultrasonic I'm going for.
Yes.
Just remove that ledge, yeah.
Yeah, dry ultrasonic, but then followed with waters with ultrasonics, because sometimes the dry ultrasonic tends to accumulate debris. Yeah, you get a lot of debris and that's sort of pushed into the canal. So definitely for trying to gently remove it, and then followed by a water flush as well with the ultrasonic. Goosenecks, again, really, really useful for this canal. I tend to not go into it straight away with a hand file. This is the one canal that I actually use a rotary first. So I tend to use the XA just to enlarge the canal orifice, because what you find is with MB2s, the first 3 millimeters are really curved. So if you manage to eliminate that curve a little bit, your hand files will actually go in without ledging the canal. So I tend to go in with an XA first.
Because I always felt that it was more that I just was sort of always scared of going too mesial and then not taking away enough, so I'm having to, but actually the anatomy normally is just more curved.
Yes, it is. So I mean, you don't want to take off too much with your gooseneck or your ultrasonic, but this is where the rotary file is really useful, because once you've uncovered it and the canal orifice is not on the wall of the tooth but on the floor, then as soon as you take your XA in, it will tend to, if you brush away from MB1 in that direction, then because the canal will tend to want to slip in, towards MB1. So you've basically eliminated that first 3 millimeters of curvature. Then take your hand files in. Then they tend to go to length a little bit better.
Because I guess it has to curve more, because again, you'll know these better, but a large percentage of them are adjoining MB1 at some point.
Yeah, right? a really, really big number of them do join into MB1 at one stage. Obviously, they can be completely separate, which often happens when endo fails. If you've done an upper six and it's failed, and you've still got a lesion on the mesial root, sometimes it's because MB2 is separate, or is separate for a large chunk of its anatomy. So yeah, it's I'd say that's a good tip on finding MB2. Upper sevens can be a little bit more tricky, actually, because just in terms of access, it's more difficult to find. But again, similar location. So you join a line between platal and MB1, dissect that line with the distobuccal, and that's generally where they lie. I was going to say something and I've forgotten. I always prepare MB1 fully before I even think about taking files into MB2, for exactly the reason that you said. Because MB1, they tend to join into MB1 at a tight curvature. So if you've enlarged MB1 enough, then hopefully as you're going in, joining into it from the MB2, it slips in rather than sort of hits a wall.
Fine, because then you could potentially ledge it where it joins in.
Yeah, exactly.
Yeah. Fine. So then, and that you look for bubbling, right? Am I thinking that?
Yeah,
right?
you can do. Often you don't see bubbling, actually. You
need those 5.5s.
Yeah.
Or you're 10 times.
You probably need like 1/16, to be honest. Yeah,
I know that's a thing.
Bubbling with sort of calcified canals where they are. I think it's quite rare that you actually see that, to be honest.
It's a myth. It's a myth. And then other things. Well, if we're looking at extra canals, lower incisors.
Yeah, a big one that catches people out. Probably the hardest tooth to treat in the mouth for me, actually, the lower incisors, because they're tiny little teeth and they're packed with anatomy. So about 40% of them have 2 canals, which is obviously a huge number. And it tends to be the buccal canal that we find and the lingual canal that we tend to miss. So it can be really difficult teeth to treat, actually. So the first thing you do is go and open the buccal canal, which is the one you naturally lie into. And then it would be sliding down the lingual wall trying to find it. And some of the lingual canals can sort of split off the buccal at quite a 90-degree curvature. So really difficult teeth to treat. And actually, I tend to take cone beam CTs before I even treat these teeth now, just to see if there is 1 canal, 2 canals, where they split. Because I find it enables me, even if there's 1 canal, for me to be more conservative with my prep. Rather than me then searching that lingual wall for
Looking for it, yeah.
That I find that, you know, in my mouth, if I wanted it done, I'd want cone beam CT done. You know what you're dealing with, and then you know what you're looking for as well, and it saves you missing those extra canals. So, yeah.
Any other teeth specifically where you're going straight for sort of cone beam?
Upper 6s more and more I'm taking them, just, and upper 7s, so upper molars, just to be able to see if there is any missed anatomy. Other than that, I mean, to be honest, I'm taking more and more cone beams before, you know, than I
like retreatments as well.
Yeah, I do tend to. A little bit more in one of the practices because I have the cone beam there, whereas in the other practice, because I don't have a cone beam on site, we are getting one, but you know, it just means that I have to send the patient out, which means it's more difficult. Whereas, you know, if I had one on site, I'd probably be taking it for a lot of teeth that I, you know, I'm doing a bit more guesswork. I'm not saying the guesswork is bad, because, you know, I think there's most canals we tend to find and it's not a problem. But I think having that roadmap is really, really useful. So yeah, I do tend to like having a cone beam before now. So it tends to be retreats that I like to take it for. But definitely all lower incisors and upper 6s and 7s, that if, you know, if the patient, I'll go through the pros and cons of it. And if the patient's keen to, you know, have it done, then I will tend to do it.
And then, I mean, I've done an upper 4 with 3 roots. That was fun.
Yeah,
that was fun. It was literally like it was like a little molar. It was, it took me forever, but it was one of those ones I was just like, no, I can do this. I'm going to do this. And,
good on you.
It was on the NHS as well. I lost so much money.
But you improved those skills.
yeah, and then don't do endo anymore. So, but no, it was so. How common is that? Sort of 3 roots or 3 canals?
Not that common. It can range from about so depending on if it's an upper 4 or 5, probably about 5 to 6%. So it's fairly chunky actually. But yeah, it's usually you'll have 2 buccal canals and 1 palatal canal. So that's, you know, what you're looking for. Very difficult actually, because the buccals tend to split quite deep in some cases. So what you tend to do is prep the ones that you can find, then go back in, dry the canal and see if you can see anything on the side. Sometimes on the radiograph you will see that the anatomy just doesn't look quite right. Things are off center, and you know, teeth like to be symmetrical generally. So if you see something going off to one side, then you think, okay, maybe there is another canal there.
And that's like with your upper 5s, because upper 4 you always, you know, barn door you look for your 2 canals, but the 5s you think, oh sweet, easy one straight down the middle, but could be quite easy to miss it.
Yeah, and about 25% of upper 5s have 2 canals. So again, symmetry, having a look, seeing, you know, prepping the canal that you're working on, seeing if it's, you know, in the middle of the tooth, and if it's to one side slightly, then looking on the other side and opening the access a little bit more. Cone beam CT obviously helps loads, but we can't take that for everyone. You know, a lot of patients can't afford it, or, you know, access and things like that. So, you know, looking for the symmetry is really important. For lower incisors as well, like if you're seeing your GP go slightly off, you know, if you're expecting something down the middle, if you see something going slightly to like that, you know that there's probably another one. Even taking a parallax is really useful when working on lower incisors, to see if it's, you know, going off to one side or not.
And then any other weird and wonderfuls? That's pretty much it,
I mean, all teeth can be weird and wonderful, so that's why endo is so interesting. So other common ones, I mean, I know we talked lower canines, 15% can have 2 canals. Again, lower 4s and 5s, we can have 2 canal, commonly 1 canal, but often we can have 2 or 3 canals. Lower 6s, really very commonly can have an extra distal canal. So about 25% or so can have 4 canals. So again, it's looking for your main distal, checking if it's in the midline of your MB and ML. And if it is bang in the midline, okay, there might be just one, but if not, if it's off to one side, then to look on the other side for the second distal. And lower 7s.
Mid-mesial as well? Mid-mesial?
And middle mesial, yes, very good. Yeah, 15% can have middle mesial.
I haven't found one of those, do I? 15%?
Yeah, it's quite significant, yeah.
So that's upsetting because I've definitely done at least 10 lower 7s, so I've missed one somewhere, haven't I?
Yeah, most commonly
numbers,
in lower
big
6s,
numbers.
actually. Most commonly in lower 6s.
Okay.
Can be in lower 7s as well. Actually, lower 6s, if we're talking about really weird anatomy, can have 3 distals, sometimes 4 distals, just, distals on its own. I think the most I've found in a lower 6 is 6 canals. So it's, can have quite a significant number. And lower 7s can have a C-shaped canal. So sometimes just 1 canal and just, a big C shape. So
and how do you go around? I'm guessing that's going to be more sort of a thermal obturation and
yeah. I mean, they can be done with cold lateral and trying to fill the C that way, but far more predictable with a warm technique. So warm vertical condensation probably is the technique that you choose to do if you have that available.
Well, that was the one thing on materials and equipment we didn't go into. What's your obturation? Because we were going to go through like it's almost a step by step, but we're definitely not going to have time, so you're going to have to come back on at some point. But let's just talk about sort of obturation a little bit and what sort of materials and equipment you use. And guys, if anyone's got any questions, pop them in now, and I'll get through as many as I can. But yeah, so let's go obturation. So what have you got? Specific brands, materials?
So I tend to like warm vertical condensation. My obturation unit of choice is the Elements by Kerr. I really like it because I find it basically has a cartridge based system. So warm vertical condensation is where you basically put your master cone in, you use a heated plugger to down pack. So you basically pack right down to about 5 millimeters from the apex, pull out the coronal GP, so you're left with just your 5 millimeters apically, plug that down, so you basically have a nice fill now of the apex, and then you use a hot GP, so a warm one to backfill the canal and obturate the rest of the canal, so you get a good 3D obturation. And the backfill device on the Elements unit I find a lot better than the other units, because some of them come where you basically put a warm capsule of GP in there and then you squirt that out, and the whole unit gets really messy. If you can imagine, like melted GP everywhere. And quite often your nurse struggles to clean it, and then you're squeezing it out, it's not quite warm, and then sometimes the plastic on the unit can break, and these are really expensive units. They come to about sort of £1,500. So when it does snap, and it happens all the time, it's a real problem. At Guy's and at King's we have units like that, and the amount of ones which have broken and have to get sent for costly repairs is crazy. Whereas the Kerr unit, the backfill device comes in a little capsule, so you warm it. When the capsule's finished, you discard it and put a new one in, so everything's really clean. You don't have sort of melted GP everywhere. So I really like the Elements IC unit. In terms of sealer, I'm still quite old school. I quite like a zinc oxide Eugenol based sealer. I again use Pulp Canal Sealer by Kerr. I really like it because I can mix it to the consistency I want, because it comes in a powder liquid form. So sometimes if I've got a wider apex, or I'm close to the ID nerve or the mental nerve, I'll mix my sealer a little bit thicker, so that I'm not worried about extrusion or sealer puff in the area that I don't want it. If I suspect there's a lateral canal, or there's a interesting split somewhere that I know that I have, then I can mix it a little bit more runny, so it means that that those areas get obturated a little bit nicer. So I quite like having that that sort of flexibility in my sealer
control. Yeah.
Exactly.
We've just had a question actually pop up on warm vertical. So how do you prevent extrusion? If you're obviously saying you're going for it, you're pressing that down. So what's the sort of, obviously you've got the cone fitted, right? You're saying it's a fitted cone already.
Yeah. So that's where apical gauging becomes really important. So apical gauging is where you're checking the size of your apex. So for example, you might have prepared your canal to an F1, so you would expect it to be a 20 at the apex. You know, the width of the apex should be a 20. But actually in many cases, especially when teeth are necrotic, you can have a little bit of apical resorption. So that apex might actually be a 30 or something like this. So after you've finished preparing your canal, you basically use hand files to push down, finger pressure on the top of your hand file and see if it's going through the apex or not. And the one that doesn't go through the apex means that, you know, that's the length, the width of our canal at the base. So I tend to use an apical gauge to then gauge my GP points. I guess that's getting quite technical if you don't know what those bits are, but it's basically where you adapt your GP point to become a size 30, and there's little devices that come that, you know, enable you to check that and to make that. So that way, when you're pushing down, you know that your GP point's not going to come out the end. I also tend to use slightly smaller GP tapers. So if I've prepped to, for example, an F1, I won't use a matching F1 GP point. I will use something that's a smaller taper so that my GP point is not locked on the taper. I know that it's locked actually at the base. So if I push down, it's not going to come out the end, if that makes sense.
You're just getting that vertical, yeah.
Yeah, so it's basically, for example, if F1 is like a 7% taper, I'll use a 6% cone or a 4% cone. So I know that only the apex is locked when I'm checking my tug back. It's not getting, you don't get taper lock, we call it, where the taper is actually locked, but the apex is free. So when you push down, then obviously if it's only locked at the taper, it will come out the end. I hope that makes sense because it's difficult to explain.
Absolutely. Well, we're gonna have to leave it here because we get cut off at an hour still, I think. So we'll definitely have to get you back on at some point if that's all right.
Yeah, it's been really nice. Thank you for having me.
No, it's been great. I think so many little tips and tricks. So I mentioned it earlier, the online course. When's it coming out? Because I need to do the rest of it.
So we're hoping for a launch date on the 1st of August. It's a course. It's called the Endo Course, and it basically covers everything to do with the essentials of endo. So right from cleaning and shaping, diagnosis, treatment planning, obturation, restoration of endodontically treated teeth. So there's basically bite-sized modules on each section that you can view online. There's lots of demos and diagrams and stuff like that. So, hopefully it'll be quite useful for people to sort of have at home. So if they've got a case next week, they can just log on and find out the module that's necessary for them. So most simple.
So you can dip in and out and come back and review it.
Exactly, yeah. So it's a course to go through if you want your CPD, of course. But if you want, it's also there, for the rest of your days, really, for you to go through and for it to help you through your endos. Because we cover some advanced stuff like ledged canals, calcified canals. So if you have, like a really curved canal coming up next week and you want to refresh, you can sort of go back and have a little look on the tips and tricks and things like that. So
someone's just asked where can I access it, because it sounds amazing. So where is it? Through your Insta? Is it website? It's
going to be a website, and it's going to be www.theendocourse.com. If you sign up to my emails, you can do that via it's not on my link right now, but it will be on my bio, and then we'll send you exactly when it launches and stuff like that. So hopefully it'll be very useful for everyone.
Now, I've seen a couple of the modules to sort of check it through for, and it's really, really good stuff, guys. So if you enjoyed this tonight, you'll get a lot out of that.
Thank you.
This has been ace. Oh no, seriously, it's really good. So it's going to be great, and you do hands-on as well. Get that plug in. So last little question. We've got a minute and a half.
Okay.
What's the one thing you do now that you wish you started doing, way earlier? Is there a top tip for young dentists or something like that?
So when
it doesn't have to be about endo.
Okay. Well, mine is about endo because I'm all endo related. But so the one I can think of is before I used to start my endo straight away. So say there'd be a restoration in a tooth, I would go through, do my endo with the view to, okay, maybe later if it needs changing, I'll change it. Or I put my crown on top of that old filling, thinking that would be fine. Now I tend to strip the tooth completely before I start my endodontic treatment, and it does take longer to then start your endo. So Obviously, it's a bit of a delay at the beginning, but it saves so much hassle. So you can check your restorability. You know, is that tooth restorable? Is there any caries under it? Are there any cracks under that restoration? So I remove everything first, and then I do a pre-endo restoration. So build like a four-walled restoration prior to doing the endo treatment. And for me, I think that's made a massive difference, because it means that your endo isn't leaking, like your rubber dam is, you know, nice and tight around that restoration. You've not got hypochlorite coming in the patient's mouth, you've not got saliva coming up through a wall that's missing, and you know that tooth's restorable. And you know, it's very easy at the end of treatment just to build a core in the middle. So for me, that's probably the biggest thing that I've changed, and I do think it's made a big impact on my treatment.
There you go. Perfect. It's been ace. Thank you so much, and we're going to get you back on. Is that all right?
Yeah, it's been lovely
Awesome.
lovely to be here talking to you. Great to get to know you, Rupert, as well.
Cheers, guys. Thank you so much. It's going to be on to rewatch it all on the Instagram TV and all that stuff, guys. And we'll see you next week. God, it sounds like a proper TV show, doesn't it?
Yeah.
Coming up next week, we've got Amit Patel, and we're chatting about immediate bridges. So I'll catch you then. Cheers, guys.
Bye.
Cheers. See ya.